Greetings to all my colleagues who are undertaking the course Clinical Epidemology offered by University of Eldridge. Uh, so today in week we are in week three. We are, and I hope you are having a good time with the course. So we are in week three, and we have two pair graded assignments. Uh, and in both assignments, we have to review an article and give our opinion on that. So the first part, which was regarding our discussion whether the article that is published in British Journal of British Medical Journal, so can be applied to secondary or primary healthcare, and any argument that you would disagree. Well, we all have our opinion after reading this article, and I believe that we should all have respect for mutual respect for one's opinion. So doesn't mean that my opinion is necessarily applicable. So I am looking forward to have your positive response on my discussion. So the article here is which has been published in the journal British Medical Journal. It's a very reputable journal, and its impact factor is quite high. So any article publishing in this journal, have a value and and applicability. You can say you can trust on this journal. So the title is the accuracy of clinical symptoms and science for the diagnosis of serious bacterial infection in young febrile children, prospective cohort study of 15,781 febrile illnesses. So we domain is clear. We are working on a diagnostic study, descriptive and clinical epidemiology, and of course, if it's diagnostic, it has to be prospective. So first of all, I would just want to just have a brief review of the paper. So we can say that sample size is quite large, and they have a research question at their disposal, that is febrile illnesses. Their domain is children, younger than 5 years of age, and they are presented with a febrile illness. So which is quite you can say that febrile illnesses in children is quite prevalent, and according to a data, 25 million episode febrile illnesses young children managed by clinician each year in the United States. So mostly the clinical visits are due to this. So first, I would like to share uh, my opinion on that paper. Well, it's a well-written paper, and 2 years it's quite a large time frame to collect data. 60,000 sample size, and they were quite to the point. The people, the researchers, they are experts, and they have cleverly selected the parameters they would validate in order to find out that a child visiting a hospital has been suffering from prior illnesses, and need more intervention or not. So first of all, I am clear on that the model cannot be applied in primary healthcare, because the study itself has been conducted in secondary healthcare, in a hospital. So I we cannot apply the study of university on college or school. In the same way, any study that has been conducted in school cannot be applied to college or university. So a study that has been conducted in a secondary healthcare setting cannot be applied to primary healthcare. Or as you know that primary healthcare there are only community pharmacies and general physicians. You are using visiting a private clinic for a checkup. So just I have listed a few of the things in my, you can say, the argument where I say that this study can only be applied to secondary healthcare and cannot be primary, because you can see that follow up is not so frequent in clinics on or community pharmacies. So just patient came, they tell you their signs and symptoms, and they just go away with the prescription. So follow up is quite difficult. So then the reviewer, in clinics and pharmacies, you see that a large influx of patients. So it's really difficult to have a follow up in primary healthcare setting. So also the electronic record keeping is very actually controversial, I would say, because it can be easily manipulated. In primary healthcare setting, not many people are involved in clinical decision making. Usually have we have a doctor who checks you for your signs and symptoms, and then he give you prescription. So follow up, and review, it's difficult in primary healthcare setting. Then it's time consuming, of course. They have almost 40 parameters, sign and symptoms they included in their model. So in a primary healthcare setting, it's very difficult, for a doctor or for a physician, who have a large influx of patients waiting outside, sneezing, coughing, and just compensate almost the data they are assessing. It requires at least an hour to assess. So I think it's and in primary healthcare setting, physicians are usually giving 5 to 10 minutes to patient. So really difficult, time consuming. So patient load, and if you want reference standard here, they use actually the culture test. They did the culture test, blood culture test for for having a definite diagnosis. So it usually requires more than 24 hours before we have the cultures, and have a growth. And from there we can, obvious that it has some sort of the infection because of a bacteria. So in primary healthcare setting, so of course, we cannot avail this facility more often. And the sound knowledge of statistics, because the model requires a statistical regression. It's multivariable, so more, not more of the you can say that physician have a, good interest in applying statistics to their patients and their signs and symptoms. So in primary healthcare, we don't have people that have usually sound knowledge of statistics, computer regression, and also time is of essence. So in primary setting, I think it's difficult to apply the study results on that. So in secondary healthcare, I would say that yes, we can. So I think this concludes my opinion on the paper. So, and one more thing that I would add here, that the argument that some disagree. Well, I think this model should I argument here, and I think it's open to discussion. You may disagree, but I personally think that this model can better be applied in tertiary healthcare. But tertiary healthcare means a more specialized setting, where you have a specific cardiac center, you have a department of urology, pediatrician, psychiatry. So this model, I think such model should be applied to pediatric. This model doesn't have any general applicability, so it can only be applied to pediatric ward. So it should be present in a ward that is specialized for children. So of course, patriotic ward is the one where we can apply that. So tertiary healthcare settings, this model can be more applicable rather than primary and secondary, because even in time and everything, that the resources required to apply this model. Well, it's quite demanding. So also the method, the model is validated, but on 6000 and you can make sure. But uh, it was conducted in Australia. So I think we are people where we have a large of ethnicities and cultural differences, and developed countries and developed countries. So I think this is a model. It has the leverages and the requirements. It can only be applied in developed countries, patriotic, especially tertiary care, and even developing countries, I would say it can only be applied in tertiary healthcare. So in underdeveloped countries, so I'm not optimist that such models can be applied. So I hope that and thanks for listening to me, and I'm looking forward to to have your opinion on my, and I will inshallah definitely read for it. So thank you so much, and this is me signing off.